Thank you, Dr. Ilakya and Keetana, for your presentation.
Thank you, madam.
We'll move on to the next session. The topic is multiple pregnancy. We have moderators, Dr. Lal Bahadur Palo, sir, and Dr. Nirmala ma'am.
Good afternoon, madam.
Dr. Lal Bahadur Palo, sir, is professor, Department of OBG in Pondicherry Institute of Medical Sciences. He had won award in late Dr. Tripta Ranikar Prize Awards, publication both in national and international journals, and special interest in iris pregnancy and benign gynecology.
Avni?
Dr. Nirmala Jagat ma'am, she is professor in Sri Venkateshwara Medical College. She has professional experience, 20 years in obstetrics and gynecology, 14 years of teaching experience, publications in national and international journals, fellowship in gynec endoscopy, trained in infertility, and field of interest is safe motherhood and adolescent health and gynecological surgeries. We welcome you, sir and ma'am. And I invite Dr. Ashwin Anthony Jose and Dr. Vinod Kumar. Please introduce yourself and share your PowerPoint.
Valu sir and Dr. Nirmala.
Good afternoon, madam. Good afternoon, madam. Yes.
Good afternoon, ma'am.
Thank you for giving the opportunity, madam.
Okay, thank you. Thank you. Valu sir has joined.
Please introduce yourself.
Valu sir, unmute yourself,
Who is
sir.
Dr. Vinod Kumar?
I am Dr. Vinod Kumar from
Valu sir,
postgraduate.
unmute yourself, please.
Okay, introduce Vinod and Ashwin. Introduce yourself.
I am Dr. Vinod Kumar, postgraduate final year from Pondicherry Institute of Medical Science, and along with me, Dr. Ashwin, postgraduate final year, Pondicherry Institute of Medical Science. We are presenting multiple fetal gestation case presentation.
So the virtual screen is dominated by male PGs and male gynecologists.
Yeah, but they are being from all from the same institute also.
They are majority, madam. So I'm letting them
Yes.
dominate.
We'll start the case, madam, without.
Yes.
Yeah.
Yes, yes, yes.
Yeah. Fine, madam. Please, Ashwin and Vinod, please present your case.
Yes.
Ashwin, do you want me to share the PPT?
No, madam. Is it coming, madam?
No.
No, we are not able to see.
Okay. Okay.
Did you click share screen option?
Yes, madam. We are sharing.
Yes, it's starting.
Now is it coming, madam?
Yeah. Make it full screen, please.
Yes, madam. Good afternoon. We are presenting multiple gestation case.
The slide is not coming full screen. You are full screen.
Oh.
I would like to see your slides in full screen.
It's in full screen only, no?
You touch that presentation, madam, it will become full screen.
You press on the slideshow, Ashwin.
Is it visible, ma'am?
Yeah, it's coming full screen. Go ahead.
Yes.
Now, what about madam? Nirmala, madam, are you?
No, it is not coming, sir. I'll just check in. Yeah, it is coming, sir.
Yeah.
Yes.
Yeah. A 31-year BA postgraduate, a wife of Mrs. Y, BSc graduate, businessman, belongs to upper middle class according to modified Kupasamy scale. She is residing from Pondicherry, nearby health center reached by 15 minutes from your home. She is gravid at 3, abortion 2, at 9 months of pregnancy, admitted for delivery and offers no complaints. Fetal movements well perceived, no history of abdominal pain, bleeding or leaking per vagina. No history of burning, mutilation, or white discharge. No history of fever, cough, and cold. She was
So
considered
she
by
was presented. She was presented to your hospital at 9 months only. She is not a booked case.
she is book case, ma'am.
She is a booked case.
When did she come to your hospital?
She is come from our hospital from 20 weeks of gestation, 5 months of pregnancy.
Okay, okay. Midway, okay.
She is considered by first cycle of ovulation induction with tablet letrozole 2.5 mg for 5 days and UPT positive at 35 days of amenorrhea. Intrauterine twin pregnancy confirmed by ultrasound at 6 weeks. Routine antenatal blood investigations done. No history of excessive vomiting, fever with rash, exposure to radiations or drug intake. No history of lower abdomen pain, bleeding or spotting per vaginum. Ultrasound done at 8 months, third month revealed to have live twin gestations to be normal. She was asked to continue folic acid tablets along with tablet dydrogesterone 10 mg BD till third month of pregnancy.
Okay. Hold on here. Hold on.
Yes, sir.
She, by now you told she had done 2 scans and some investigation, routine investigations.
Yes,
These
yes,
are from your hospital, not from your office, from somewhere outside.
Yes, sir. She is booked outside.
Okay, fine. No, she was showing outside till then. So what do you
Yes, sir.
expect?
Yes, sir.
Okay, what do you expect in a 6 week scan? What do you expect to see in a 6 week scan?
In 6 weeks scan, we first we have to determine whether it is intrauterine pregnancy or not, and viability of the fetus and
The
chorionicity of the.
No, don't jump into chorionicity. Anything else?
We have to look for the fetal viability,
Viability?
gestational age, exclude major anomalies, and
6
chorionicity.
weeks.
No,
6
no.
weeks, how will
6
you?
weeks.
From 6 weeks, we have to intrauterine gestation.
Okay, that you told. That you told.
And
Any
gestational
other
age.
thing?
Yes, gestational age.
Ectopic pregnancies,
Ectopic.
molar
And even
pregnancies.
uterine pregnancy, yeah.
Yeah. Okay. Then you did another scan. Somebody did a 3rd month.
Yes, sir.
Yes, sir.
Okay. What do you
Yes, sir.
expect here to see? And multiple pregnancy also you can detect at 6 weeks. Yes. Can you see
Yes,
some signs?
Yes, sir.
Yes, sir.
Yes,
Yes,
sir.
sir.
Twin peak
Ah.
sign.
Oh, no twin. We'll see that. So
Yes.
6 weeks you can see some sacs at least.
Yes, sir.
Yes,
Two
sir.
gestational
Oh,
sacs.
okay. So what is the 3rd month? What they did? What did they see in the scan, or what is the scan report? Or if not there, then what is supposed to be seen?
In the 3rd month scan, we are supposed to see chorionicity, amnionicity, and we should look for uh, twin peak signs or lambda signs, or look for nuchal translucency, and to exclude major anomalies like anencephaly or large cystic hygroma.
Okay, so in a multiple pregnancy, you are supposed to what is more important? Zygosity, chorionicity, amnionicity, what?
Chorionicity is more important, sir.
Oh, okay.
Because
How do you find out zygosity? Tell me how by the ultrasound.
diversity by ultrasound, usually the scan will be done around 11 to 13 weeks plus 6 days period of gestation, or the crown lump length between 45 to 84 mm. We should look for chorionicity. So in that number of
Zygosity.
placental masses we can look for. Number of placental masses and the membrane thickness we should look for. If membrane thickness is more than 2.2 mm, it is dichorionic usually, and look for signs of twin peak signs or lambda sign in dichorionic diamniotic twin gestations, whereas in monochorionic the membrane thickness is less than 2 mm, and there will be a T sign.
You told you will do NT scan also. Why
Yes,
you want to
nuchal
do NT scan?
Yes,
Why
we will do. What's
Sorry, sir.
Yes. Why you want to do an NT scan?
We have to aneuploidy is more common in multiple pregnancy, especially more common in monochorionic twins than the dichorionic twins. So we look for NT scan and
NT scan alone may not help you. No, along with that,
NT scan along with markers can be done, sir.
markers can be done, sir.
For detection of aneuploidies, sir.
What markers you are
But
talking
markers
about?
can you do in
Madam, go
multiple
ahead.
pregnancy?
Madam,
Yeah,
please.
no, sir. Continue,
Hey,
sir. Continue.
You ask. Please.
Yeah.
Ask.
Whether markers will be reliable in multiple pregnancy?
No, ma'am, it is high false positive rate compared in multiple pregnancy than this singleton pregnancy. The false positive rate in multiple monochorionic twins it is 10%, whereas in dichorionic twins it is 5%, whereas in singleton is 2.5%. So
Is it-
usually,
Okay. Continue.
So,
Will it be affected if the one twin is vanishing? Can we do for the remaining live twin? Whether it will be reliable then?
20.
I'm asking about the markers, serum markers. Whether serum markers will be reliable if the one baby is dead.
No, ma'am.
So
Still,
for the
it is not.
What will happen? What will happen?
Because
There will be no false positive.
Alpha fetoprotein level will be high. Alpha fetoprotein level will be high. So that's why it will not be reliable. Okay. And why this patient ovulation induction was done? I think she already had 2 pregnancies, right?
Yes, ma'am.
She is gravida 3, abortion 2.
Yes, ma'am. Actually,
Why ovulation induction was done? Did you ask?
Yes, ma'am. We asked actually patient had a history of she is no case of depressive disorder and she was taken on anti-depressive drugs. And after that, during evaluation, she was found to have a hyperprolactinemia and she was started on cabergoline and she was treated with cabergoline. And after that, she was started on ovulation induction also.
Okay. Fine.
No, you
So you have told that other investigations have been done.
Yes, ma'am.
Okay, sir. Sorry, sir.
No, madam, go ahead.
And you have told that other investigations are done. So whether something has been evaluated since she had 2 abortions?
No, ma'am. She is not investigated for that abortion.
No.
Okay. So what investigation you should have done?
We should, in case of recurrent.
What investigation you should have done? Now she is already pregnant. She is already pregnant, right?
Yes.
So we have to avoid another abortion.
Yes,
right. So what investigation you should do?
We can rule out in recurrent abortions. We can rule out APLA also, ma'am. But it is not advisable during pregnancy. During inter-pregnancy interval, we can do APLA investigations, or otherwise we will do
beta-2-glycoprotein.
No.
Anything else? In that case, first you should think about what are the causes of recurrent abortion.
Yes, ma'am.
See, APLA we cannot do, but maybe patient had diabetes, maybe patient had cervical insufficiency.
Yes,
okay, so all these things we can prevent. No, still, if diabetes is there, so early screening for diabetes should be done. You should look for the cervical length. Earliest we should,
What are the past history of past pregnancies?
At what gestation the patient was aborted?
Go ahead with the presentation.
First abortion is at 2.5 months of gestation. She was diagnosed as
your presentation. Show your presentation.
Yes.
First
conception is 2018. That was spontaneous conception. At 2.5 months of gestation, she was diagnosed as anomalous fetus. By history-wise, she is telling some cystic lesions are on the neck of the fetus. So probably it is due to a large cystic hygroma. Medical termination of pregnancy was done by dilatation and evacuation. And second pregnancy is spontaneous complete abortion at 1.5 months of gestation.
Okay, what was the gap between the first and the second pregnancy? Okay, right,
2 years.
2 years, 2 years. Okay, fine.
Almost.
You can go back to your presentation.
There is no history of excessive vomiting, no history of fever with rash, no history of exposure to radiation, no history of drug intake, no history of lower abdomen pain, no history of bleeding or spotting per vaginum. Ultrasound done at yes. Quickening was felt at 5th month of pregnancy. No history of headache, blurring of vision, epigastric pain, reduced urine output, no history of abdominal pain, leaking or bleeding per vaginum.
Why did you ask? Why did you ask her about the history of headache, blurring of vision, epigastric pain?
Yes, we asked because of gestational hypertension or signs of imminent eclampsia.
Then patient will, so all these things you will ask only when the patient is either she's complaining of that edema is there, which is not comes under gestational hypertension, but maybe on examination you have found that patient is having gestational hypertension. What are these symptoms suggestive of headache, blurring of vision, epigastric pain?
It is the symptoms of eclampsia.
Imminent eclampsia, right?
Imminent
So
eclampsia.
have imminent eclampsia, first you have to diagnose preeclampsia, right?
Yes.
So if the patient is not having, then you are not supposed to ask. Is your patient is having because now
No,
she's 9 months.
She's not having
She's
gestation.
not having. Then you're not supposed to ask. It means then you are supposed to ask for all the patient that whether you are having giddiness, whether you are having blurring, means like palpitations, and also for anemia also.
No.
Right?
Yes. Okay.
So
because
until patient is no, this is because I have seen frequently all students, not your only postgraduate, undergraduates also. Okay, that everybody is asking that in second trimester history of headache, blurring of vision, epigastric pain. So these are only you have to ask in cases of where the patient is already you are diagnosed as either gestational hypertension or preeclampsia to determine the severity. The patient who are not having anything means suggestive of gestational hypertension, preeclampsia, you are not supposed to ask this. Right? Okay. You got my point now?
Yes, ma'am. Yes.
Yeah. Okay.
And virginity was done at 6 months of gestation by 75 grams of oral glucose, which is said to be elevated and diagnosed of gestational diabetes mellitus, and start on medical nutritional therapy. Blood sugars were monitored after 2 weeks of diabetic diet and found to be normal. 2 doses of TD were taken and iron and calcium tablets taken.
How much was elevated? The blood sugars were elevated.
The fasting is 1 or 2, ma'am. Postprandial is 150. 153, and after the second hour of glucose it is 184.
Okay, fine. Okay, continue.
Fetal movements were well perceived. No history of abdominal pain, leaking or bleeding per vaginum. No history of excessive weight gain or visual disturbances, headache or vomiting. Ultrasound done at 8 months revealed twin with normal growth parameters and normal lighter.
Again, here you have written, again you have asked excessive weight gain, visual disturbances, headache or vomiting. That means again you are suggesting that patient having preeclampsia.
Yes, ma'am.
Abdominal pain, leaking, bleeding PV I can understand. Okay, because these patients may be having means risk of preterm labor, so maybe abdominal pain you have to ask. Bleeding PV because chances of maybe APH, maybe there. But means visual disturbance and headache again means it suggests that patient is having preeclampsia. That's why you are asking. Okay. Next.
Menstrual history, menarche attained at 13 years of age. Her LMP is 17th April 2022, and cycles are regular, 3 to 4 days flow for every 30 days cycle. Expected date of delivery is 24 Jan 2022. Period of gestation is 36 weeks plus 4 days period of gestation. Marital history, married since 4 years, non-consanguineous marriage, no history of contraception. Shall I proceed?
Yeah, go ahead,
Yes,
go
yes.
ahead.
Go ahead.
Past
Already
obstetric.
told, already told. Chalo, go ahead.
Yes. Past history, she is known
Oh,
case of.
she did a scan also at 5th month.
Yes, sir.
Yes, sir.
You mentioned sometime. What is that 5th month scan is for what? By now you know she's a multiple twin gestation. What is
Yes.
the scan for?
5th month scan is for detecting anomalies, sir. Major fetal anomalies and
Cervical length.
cervical length, and to determine the Liker volume,
Yes.
and in case of monochorionic pregnancies, that is if we suspect twin pregnancies, scan should be done at early 16 weeks period of gestation to look for the Liker volume, deep vertical pocket, and umbilical artery pulsatility index,
Okay.
and fetal bladder.
That we are not
So-
discussing now. No, that we are not talking now. Now, what is your, after this, what is so far, now that after 5th month, this lady has come to you. Is that right? So,
Yes, sir.
what you would have followed up till this 20? This 20 weeks is more important in a
Yes,
multiple
sir.
pregnancy, the first 20 weeks.
Yes, sir. We will look
How,
for detail.
if you would have been the doctor for her, then what you would have done? Tell me.
We have to look for a detailed structural anomaly and of the fetuses, and we also have to look for the heart evaluation of the fetal heart to be done to
When
exclude
fetal heart
functional heart.
evaluation has to be done.
No, not now. From the very beginning, you tell from 6 weeks what you would have done, or after the 14 weeks, 13 weeks, that 3 month scan, what you would have done. Now, what you would have done, and you tell details what you would have done, because there's nothing in the scan, no scan report with you. No, you are
Yes,
not
sir.
supposed to see the scan report also. No, in exam.
Yes, sir. During. So in fifth month scan, we should look for detailed anomalies.
You
And
go to 6 week scan, or say what you would have seen. Multiple
weeks.
sacs you would have seen.
Yes, sir. Multiple sex.
When you see, then when you ask the lady to come again to look for this zygosity and chorionicity.
Yes, sir. At 11 to 13 weeks, 6 days.
14,
Okay.
14, 11 to 14 weeks. Between.
Okay, that time you suppose you could you confirmed it. So what are the types of twins? We'll restrict to twins only. What are the types of twins you would have found out? What are the possibilities?
what are the we should find out dichorionic diamniotic twins or monochorionic diamniotic twins, monochorionic monoamniotic twins. And,
Okay.
Which type of twins is more common?
In monochorionic.
Dizygotic twin, what is most common first? What is the
Dichorionic diamniotic is more common.
okay? That is the only dizygotic twin. That is the only chorionicity.
Yes.
Okay. In
Yes.
monozygotic, there are 4 types. What you told.
4 times.
Yes, sir.
Yes, sir.
Okay. Out of
In
these
that-
4, which is more common?
Monochorionic diamniotic is more common in monozygotic twins.
Okay.
Yes, yes. Okay.
Okay. If that is the case, then how would have you followed? Suppose it is not a dichorionic diamniotic twin. It is a monochorionic diamniotic twin. Suppose.
Yes, sir.
Then how would you have followed her up from 14 weeks onwards?
So in that we will do ultrasound from 16 weeks onwards for every 2 weeks interval from till delivery, sir.
Every 2 weeks
According-
interval. For
Yes,
what?
2 weeks. To,
For what?
To look for fetal discordancy, we look and estimated fetal weight,
deepest vertical packet and umbilical artery pulsatility index and middle cerebral artery peak systolic velocity and ductus venosus.
Why all these things you want? What are the complications you look for?
So complications specific to monochorionic twins we look for, sir, like a twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, a trapped twin reversed arterial perfusion,
Selective fetal growth restrictions.
and selective growth restrictions, sir.
Okay. What else?
So if the twin, if it is a monochorionic twin gestation, we do scan every 2 weekly, sir. So every 2 weekly we have to call her for 11 antenatal visits, 11 visits we have to call her if it is a
No, don't tell
monochorionic
11
twin.
visits. Every 2 weeks you are following up. And when you are supposed to diagnose TTTS?
Usually the TTTS usually
Before
diagnosed
26
between
weeks.
16 to 20 weeks. Before 26 weeks,
weeks.
it is most commonly we can diagnose.
Okay, fine. So for that reason, you are doing it every 2 weeks. Okay, fine. Then suppose you found TTTS, then what you detected TTTS. What are the various treatment options you know?
Yes, sir.
How TTTS is staging, you know?
Yes,
Yes,
sir.
Staging.
Yes, sir.
we have to stage TTTS by Quintero staging, sir. Stage 1 is a significant discordance in amniotic fluid volume, that is oligohydramnose with a deep vertical pocket less than 2 centimeter in the donor twin, and polyhydramnose with a deep vertical pocket more than 8 centimeter before 20 weeks of gestation, and more than 10 centimeter after 20 weeks of gestation, and donor bladder will be visible. And for stage 2 is donor bladder will not be visible, and there will be normal Doppler parameters. And stage 3 will be, there will be abnormal Doppler parameters, and there will be abnormality of the umbilical artery velocity in the donor twin, and there will be abnormal ductus venosus Doppler in the recipient twin. And stage 4 is there will be ascites, pericardial effusion, and hydrops of the recipient twin. And fifth is there will be demise.
Okay.
Demise of either of the twin.
So the main aim is to catch the TTTS as early as possible. Is that right?
Yes, sir.
Yes, sir.
Okay. So what are the various treatment options? And Ashwin, you are not seen completely. Your face is half visible. Please move the camera a little. Yes. No, still not properly visible. You come closer. Okay, steady. Okay, good. Go ahead. What are the various treatment option, or what is the option you can say?
The option for if TTDS is diagnosed before 26-week period of gestation, fetoscopic laser ablation is recommended than the amniocentesis or septostomy.
Okay, fine.
What is TAPS?
Madam, yes, madam. Go.
TAPS is at it occurs in monochorionic twins. 3%, ma'am, and in TTTS treated with fetoscopic laser ablation, it is the twin to twin transmission to twin anemia polycythemia sequence, ma'am. Here the donor twin is anemic, and the recipient twin is polycythemia. The donor twin by ultrasound peak systolic velocity, middle cerebral artery peak systolic velocity for donor twin, it is more than 1.5 means of meridian, and for the recipient twin, the peak systolic velocity is less than 1 means of meridian.
Okay, less than 1 or yeah. So how do you suspect? When do you suspect whether there will be polyhydramnias or any discordance will be there?
We have to detect by using MCA PSV Doppler, ma'am. There will be signs of fetal anemia will be there in MCA PSV, and
Okay, so
there will
here,
be no significant oligo or polyhydramnose will be there, ma'am.
okay, fine.
Okay, so the main aim of your following up from 16 weeks onwards is to catch the complication. Yes, is that right? Okay.
Yes,
what is selective growth restriction?
Selective growth restriction here, the estimated fetal weight discordance is more than 20%, sir.
More than 20%.
It is calculated by formula weight of larger twin minus weight of smaller twin divided by weight of larger twins.
Multiplied by 100.
Yes, sir, into 100.
Oh, that comes in. Okay, fine. That is more than 20% discordant. Yes, ma'am.
Yeah. Is IUGR common in multiple pregnancy?
Yes, ma'am.
So how do you diagnose IUGR?
IUGR, selective fetal growth restriction, it occurs in 10 to 15% of the monochorionic twins, ma'am. And it is mostly diagnosed by using ultrasound after 20 weeks period of gestation. There are three stages. The stage 1 is there will be growth discordance with positive diastolic umbilical artery waveforms. Stage 2 will be growth discordance with absent or reversed end diastolic.
I'm not asking about the discordance. I'm telling both baby can be growth retarded, right?
Yes, sir.
Because they are fighting for the whatever the available nutrients for the this thing only. So how do we diagnose?
How do
In twin
you
pregnancy, how do we
IUGR?
diagnose IUGR in twin pregnancy?
Estimate based on estimated fetal weight
Liker will be less, ma'am.
based on estimated fetal weight and abdominal circumference, ma'am. If estimated fetal
So
weight,
we take the same criteria like a singleton pregnancy.
Biometry.
Whenever the same curve only we use, even for whatever we use for the singleton pregnancy. Here also, so whenever the growth is falling less than 10% percentile, it is called IUGR. So even both the babies can be IUGR, and there also the discordant twins also can be there. So there will maybe difference between the two twins, 20% of weight difference. Okay.
What are the various maternal complications that can occur apart from these complications? Tell me common complication common to both dizygotic and monozygotic twins. Common
maternal complications: hyperemesis gravidorum, anemia, gestational diabetes mellitus, gestational hypertension, eclampsia, preeclampsia, polyhydramnios, and abruptio placenta. Abruptio placenta, placenta previa, high risk for operative vaginal delivery, high risk for cesarean section, postpartum hemorrhage, postpartum depression, and for a fetus specific to monochorionic twins and non-specific complications. Non-specific complications: abortions, chromosomal abnormalities, congenital anomalies, growth discordancy, and fetal growth restrictions, preterm labor, single fetal demise, stillbirth, and increased perinatal mortality and cerebral palsy.
Okay, what is the most common? What is the most common, prominent one complication out of
preterm labor is most common. Multiple
pregnancy.
Okay, preterm labor. Okay.
Yes,
Can we predict preterm labor? How do we predict preterm labor?
Prediction of preterm labor by cervical length. If cervical length is less than 20 mm, between 20 to 24 weeks, we will predict the preterm labor less than 34 weeks. The specificity is 97%, but routine prediction of preterm labor by cervical length is not recommended by NICE guidelines and RCOG. And there is no role of fetal fibronectin in prediction of preterm labor, and there is no role of home uterine contraction monitoring.
Bed rest.
Not that is prevention.
Role of progesterone?
There is no role of progesterone. There is no role of cervical encerclage. There is no role for bed rest or hospitalization. There is no role of cervical pressure.
Prophylaxis, maybe it is not of use, but once you are predicting the patient is at risk of, patient is having history suggestive of preterm labor, or when you are finding that the cervical length is less than 2.5 cm, then maybe yes, instead of, you cannot leave the patient just like that, right? Yes, definitely there is no role of bed rest. There is no role of injectable injectable progesterone.
Progesterone.
There is no role of pessary, but definitely vaginal progesterone and cerclage where you are predicting that cervical length is less or history suggestive of. Okay, routine use is not recommended. Okay, that just because of patient is having twin pregnancy, it is not recommended, right? But what is recommended? Something is recommended. Some prevention is recommended. What we can prevent? No. It is not. I'm not talking about preterm labor. Something can be prevented. Preterm labor we have talked about that. Okay, prophylaxis is not recommended, but wherever you are suspecting that patient may go history or by examination, then maybe you can. That is also not recommended for means routinely. Then again, wherever you are suspecting that patient may deliver within 7 days, Okay, either your fetal fibronectin is positive or cervical length is less than 1.5 centimeters. So you suspect that patient may deliver within 7 days. There only
7 days.
steroid routine use is not recommended. I am asking in general, not about preterm labor. Something else can be prevented by giving something to the patient. We were talking about the risk factor or the complications to the mother. Any complication to the mother can be prevented.
Yes, ma'am. In the we can prevent gestation preeclampsia by giving aspirin.
Yes. So twin pregnancy, prophylactically, aspirin is recommended. You can if you have to start the aspirin, when you are supposed to start.
Aspirin should be start after the cardiac activity is present. We start aspirin. Low dose of aspirin, 150 mg OD. We can start.
Okay. Or if patient has not come with the cardiac activity, at least preferably for the prevention, before 16 weeks of pregnancy, you are supposed to start. Okay. If you're not already started. Okay.
Okay. So tell me what are the various. So this case is you want to present something is left out. You can present. Go ahead. Go ahead.
Family history, that is no
Nothing is there. Is there anything positive you tell? Otherwise, go ahead.
Yes.
Okay, some diet. Okay. Okay, summarize your case history.
A 31-year-old gravid 3 abortion to a 36 weeks plus 5 days period of twin gestation conceived by ovulation induction with the gestational diapers mellitus on diet control.
Okay, fine.
Here you have to tell the presentation also, no? The fetus.
No, this is summary of the case history, madam.
Okay,
Now,
okay, okay.
now
Now
they'll give
examination.
the examination.
Examination.
I'll be proceeding with the examinations.
Ashwin, you come little towards the camera. Your face is half blocked. Yeah. Yes. Stick to that place only. Okay. Chalo, go ahead. Go ahead.
On general examination, her height is found to be 165 centimeter, weight 97 kg, and a BMI is found to be 37.8 kilogram per meter square. She belongs to obese class 2 according to WHO classification, and she was afebrile, no pallor, no pedal edema. Her thyroid and breast examination was normal, and cardiovascular system S1 was normal, and respiratory system there was normal vesicular breath sounds. On per abdomen examination, on inspection, the abdomen was over distended and barrel shaped. Umbilicus was everted. There was linea nigra and stria gravidarum, and there were no scars or sinuses, and the hernial orifices were free. On palpation, the uterus was over distended. The fundal height was corresponding to 36 weeks and flanks full. On fundal grip, podalic pole of twin 2 is felt. On lateral grip, spine of twin 1 is felt on the left side, and it is cephalic pole of twin 2 is felt on the right of the umbilicus. Clinically, Liker was adequate. On first pelvic grip, twin 1 cephalic presentation, and twin 2 was cephalic, and the attitude was flexed. Symphysiofundal height was corresponding to 40 centimeter. And on auscultation, 2 fetal heart sounds were heard separately by 2 observers. It was 144 beats per minute and 156 beats per minute. And on per speculum, cervix and vagina was healthy and no abnormal discharge per vagina. On per vaginal examination, cervix was 1 centimeter dilated, 2 centimeter long, medium, posterior, vertex at +1 station. Membranes were present and pelvis was adequate. So provisional diagnosis of my case is 31-year-old gravida 3 abortion 2 at 36 weeks and 4 days period of gestation with the twin pregnancy with the gestational diabetes mellitus on diet control with the class 2 obesity with the twin 1 in cephalic presentation and not in labor.
Madam, you go ahead, madam.
Yeah. So how will you manage this case? What is your plan?
The plan of at 36 weeks and 4 days, I'll plan for admission of the patient, ma'am, and I'll first do admission and do a cardiotocogram for the patient and look for the fetal heart rate for both the fetuses, and after that, if CTG is if the non-stress test is reassuring, then we can plan for delivery of the twins. If it is as As my
Wait,
history
wait,
towards,
Delivery when? When will you plan for delivery?
as my history is most probably suggesting towards dichorionic diamniotic twin gestation, I'll most probably plan my pregnancy at 38 weeks period of gestation, ma'am.
It should be between 37 and 38 weeks. So since patient is already 1 centimeter, maybe she will go. So at least you have to wait up to 37 weeks, provided everything is all right and your patient is not having any other complication. GDM is also on diet control. So it should be 37. You should not allow to go above 38 weeks, even in diamniotic dichorionic also,
Yes, ma'am.
without any complications. Okay. It is
Yes, ma'am.
recommended since you are quoting NICE guidelines and also even NICE guidelines, ACOG also recommend that about 38 weeks, if you are allowing, then chances of complications increases. Okay. And here since patient is GDM also, so this will be added complication. So you should terminate between 37 to 38 weeks.
Okay.
Okay.
So
How will
according to
first twin you will deliver? Cephalic.
So if the first twin is in cephalic presentation,
Listen, Ashwin, this is your DCDA twin you are telling. Suppose
Yes,
she has
sir.
gone into spontaneous labor, you are in labor room. How will you deliver? First twin is delivered. Tell about the second twin delivery.
sir,
Tell about the second twin delivery.
It is essential that an ultrasound machine is available in the labor room, sir, and to look for the presentation of the second twin, and continuous CTG monitoring
Why
should
you
be done.
can't clinically you can't see?
Yes, sir.
Clinically
Clinically,
can't.
yes, sir. Clinically, it can be clinically it can be felt. And
you want to
if the
reconfirm, you can have a ultrasound and reconfirm. Okay, go ahead. Then
and if the second twin is in cephalic presentation, it can be delivered by vaginally. And if second twin is in breech presentation,
no.
then
Second twin is cephalic. What you will do? You will do ARM.
yes, sir. We have to do augmentation of. We have to give oxytocin. Then ARM can be done. Then she can be delivered vaginally, sir.
Okay, fine.
how much time can you give for the second baby to deliver? Within how much time?
Usually can be allowed for 30 minutes, ma'am. If as long as
As long
CTG
as
is
the fetal heart rate is
CTG is
good,
reassuring, we can wait for
the second twin to be
About
delivered.
30 minutes, about 30 also. About 30 minutes also you can wait.
Yes, ma'am. As
Even
long as the
CTG
CTG is
as long as
CTG is
CTG is
reassuring.
At the time the cervix will close off. If you are waiting, even the CTG is reactive. So ultimately you will go for, that is the idea that okay, about 30 minutes. Maybe theoretically it is written, but about 30 minutes practically. If you are waiting, the cervix will close off. So even if the CTG reactive, you have to take the patient for baby for cesarean section only.
Okay.
So usually if the baby has to deliver, by this time you have to augment and deliver and see the baby is all right and you have to deliver.
Okay.
So anything you can do to hasten the delivery other than oxytocin? What can you do? Oxytocin you have already delivered.
Then ARM artificial rupture of membranes can be done, ma'am.
Okay. Anything else? Cervix is fully dilated, but head is still at -1. And you have started seeing the decelerations. What will you do?
We can go for instrumental delivery, ma'am, like forceps or vacuum.
Forceps is more, here you have seen, no, the small baby only. And forceps, how can you apply? I have told you -1 station. The head is -1 station.
-1 we cannot apply.
So what you can apply?
Piper's forceps.
Piper's forceps you can apply for -1 station?
No, ma'am.
Piper is outlet forceps, no?
Yes.
Then cervix is fully dilated. Contractions are also there, but head is at -1. And patient is not pushing. You cannot apply vacuum.
Yes, ma'am. Vacuum can be applied.
That is one
but
indication.
-1.
You can apply.
Okay.
Cervix is fully dilated also, so you can easily apply. And your baby is also around 37 weeks, more than 36 weeks, so you can apply vacuum.
Okay.
Okay, and you can deliver. Okay.
Okay. Go ahead, Ashwin.
And if the second twin is in breech presentation, we can give oxytocin, then ARM, then assisted breech delivery can be done, sir. And if a second twin is in transverse position, we can do an external cephalic version, and and it can be delivered vaginally. If external cephalic version is not possible, we have to shift the patient to operation theater, and we have to try for an internal podalic version, and we have to deliver by breech extraction. If it is not possible to deliver, then we have to deliver by cesarean section.
Okay, why breech presentation we cannot do the external cephalic version? You're told only for transfers we can do.
For
If
breech
membranes
also,
are present, breech also you can do, na?
breech also we can try.
Yeah. Breech and transfers both you can do.
Both we can try.
External cephalic version. If it is failing, then you have to transfer the patient to the operation theater and then try for internal podalic version.
Yes, ma'am.
Right?
Yes, ma'am.
In transfers, breech is already there. So in transfers only you can do the internal podalic version and extraction.
Yes, ma'am.
Okay. What are the indication for cesarean section
If first
in twin
twin is
pregnancy?
in first twin in non-vertex presentation, in case of monochorionic monoamniotic twin presentation, then
In a case of conjoined twins,
Conjoined twins.
and in case of previous LSEs.
Okay. Anything else?
Anything, any obstetric
obstetric
complication,
indication
like
for,
severe preeclampsia,
severe preeclampsia, abruptio placenta,
abruptio placenta.
cord
Anything else?
prolapse.
Anything else? Fetal indications also can be there, no?
Yes,
If
ma'am.
fetus is compromised, can you give the severe
No,
discordant twins are there? Then you have to deliver by
Cesarean
C-section
section.
only.
Tell me one condition where both are cephalic, the first twin is cephalic, still you like to do a cesarean section.
If head is deflexed, sir, first attitude is deflexed. First twin cephalic, but it is deflexed.
Deflex, so it cannot flex.
If it is the pelvis is symptomatic.
Oh, pelvis. These will be preterm babies, small babies will be there. I don't think that is the. See, when the first twin is a discordant twin and is a smaller twin, and the second twin is quite big, then you cannot deliver vaginally. Is that right? The first twin, discordant twin, and first twin is small, and the second twin is bigger. Can you deliver vaginally?
No, sir.
Any other condition where you will go for cesarean section?
Conjoined twins.
Conjoined.
Okay, you told that. Okay, fine. What is the most common, you told conjoined, what is the most common, what is the type of most common? Conjoined twin, which is most common. I am not going much detail into those things.
Thoracophagous.
Thoracophagous is most common conjoined twins.
Okay.
They are usually delivered by 36 to 30. 34 to 36 weeks period of gestation, so 36 plus 6.
If it is, if there is no associated anamnesis, we can try for vaginal.
Okay. In case of twin pregnancy, can we give VBAC?
Yes, ma'am.
Yes,
We
ma'am.
can give, according to ACOG guidelines, if previous one lower
segment cesarean
section, we can allow for VBAC, but there is no associated complication, associated maternal complication and fetal complication.
Okay. But routinely, do we do? If the first baby in cephalic and other baby is non-cephalic, is it recommended? Okay, they say that, okay, you do in a double setup,
Yes,
even if you have to give VBAC also. But it is difficult, you know. Practically, it is difficult, right? When
Practically, nobody does it.
Nobody does it.
Don't add complication to complication. That is the
Yes.
dictum in obstetrics. Okay. One complication to another. Okay.
Okay. Okay, since this is your patient is diamniotic dichorionic. Okay, so you have allowed and without any complication, other added complication. So you allowed the delivery after 37 weeks also. What about the other
Yes.
type of chorionic or this thing?
In case of uncomplicated monochorionic twins, we can deliver by 36 weeks period of gestation. 34 to 36 weeks period of gestation. In case of monochorionic twins, previously complicated by twin to twin transmission and treated, we can deliver by 34 to 36 weeks period of gestation. In case of monochorionic twin, by selective with selective growth restriction type 1, we can deliver by 34 to 36. And in case of monochorionic twin with selective growth restriction type 2 and type 3, we can deliver by 32 weeks period of gestation. In case of monochorionic monoamniotic twins, we can deliver by 32 to 34 uncomplicated.
These are all guidelines, but every case here with complication, you have to individualize the case.
Individualized.
These are the guidelines. Up to this, you can wait. Beyond that, no. Okay.
Yes.
Otherwise, all cases of this complication, major complication, you have to individualize the case and take a decision, take a call. Okay.
Yes, sir.
What are the well, this is second stage you finish, then what are the complications in third stage? And what do you do in third stage? How will you manage?
Third stage, there is more risk for postpartum hemorrhage, and there is more risk for retained placenta, and secondary PPH is also common, and there will be retention of urine, and active management of third stage of labor has to be done, sir. In third stage.
Uterotonics, we have to.
Uterotonics like oxytocin has to be given for a management of third stage.
We can.
After the first twin delivery or what?
No, sir,
No, sir, after the second twin, we have to give oxytocin, sir.
This is undergraduate. Undergraduate question. Go ahead.
Then
Anything else?
there is a high risk lactation failure, and postpartum depression will become more common, and there is a high chance of venous thromboembolism. So in that case, we can prophylactic heparin we can give.
Okay. Most common complication is what? Family support, which the lady needs. That is how
depression
has to handle. Yeah. So the more needed thing is later on postpartum period is family support. Okay. Yes, madam. You continue, madam. Nirmala, madam.
I think we have our time is up only, no, sir?
Okay.
Or shall we continue?
Okay.
Or we have time?
5 more minutes, ma'am.
Okay. So from the, I think we can ask
Okay,
if
okay.
somebody is
So we
having
have
any doubt
concluded.
from the audience. Or sir,
See, we have discussed. You have discussed here only the multiple pregnancy, only the twins.
twin pregnancy.
There are higher order pregnancies. The more higher order the pregnancy, the more are the complications.
Yes.
That you should keep in mind. Second, the most important thing in twins is as soon as you diagnosed in early pregnancy, like 6 weeks, 8 weeks, 2 sacs, cardiac activity, then you have to have a repeat scan in between 11 to 14 weeks to find out chorionicity, zygosity, and amnionicity. That is the basic.
Yes.
If you cannot make out, please take the help of some senior faculty, or even fetal medicine consultants are also available in Pondicherry. You can take their help. Some people even they take the pictures and send to the higher
Okay, so here the question comes: what are the indication when we have to refer the patient to feto-maternal specialist?
Fetal, if we diagnose twin to twin transmission.
And these major complications can be found out early. That is one. And coming, and we talked about even chromosomal abnormalities will be there. They can be going for a first trimester screening with triple markers, and even not there, not done, then even you can go for quadruple marker with some what is that, pregnancy specific risk factors and fetal specific risk factors. Then of course the management part is, it depends, all depends, the route of delivery depends, all the type of twin and the fetal presentation. Type of twin means what is the chorionicity, amnionicity and all. That is the most important thing before you decide the on the mode of delivery. And the gestational age. And most important above all is the experience of the obstetrician, the clinician. That is most important. You have to take quick decision in a short period of time. That is more important. And of course, the follow-up on how to prevent all complication postpartum. Okay. So I want to emphasize.
Algorithm.
Yes, ma'am. Yes, ma'am. Please go ahead.
So that's what sir is telling. Algorithm, in short, you can say that whenever the patient is coming, okay, if suppose she is coming to you first time during first trimester, so means first trimester you should decide about whatever determine the chorionicity and amnionicity. Start her on the prophylactic aspirin, and of course you have to start on the iron and folic acid also, because these patients will be very much prone for anemia also. Okay. Second trimester, then you have to screen them for again preeclampsia and diabetes, because again they will be at risk for development of this thing. Anomaly scan. And sorry, first trimester I also forgotten about the aneuploidy. Second trimester, then screen them for anemia again and for diabetes and preeclampsia, and do the anomaly scan, and start doing the means serial ultrasound to see, depending upon that whether whatever you are finding any abnormality is there or not, and look for any complication in cases of monochorionic twins. And towards the end then of second trimester, plan for the delivery. Okay, depending upon whatever the condition of the patient is there, condition of the any complication to the mother or complication to the fetus. So depending upon that, whether you need referral to the feto-maternal medicine, the help of them, and at that time you have to plan the time of delivery and mode of delivery, and any referrals if you have. That's all.
We stop it here, madam.
Yes.
Thank you, sir. Thank you, Pala sir, and thank you.